Good afternoon. This is Toni, your HCC risk adjustment and coding specialist guru. Today's session is going to be about cancer documentation and coding in the primary care setting. This is probably the most difficult coding area, especially for those of us in primary care and not in oncology. And so I think it's something that we need to try to stay abreast of. So um, I want to try to keep it practical, something that you can actually use in your next visit note, or if you're coder or CDI at chart review. And I'm not by any means trying to turn providers into coders, but reality is a lot of providers are having to do the coding during their visits these days. Nor do I want to turn coders into clinicians. But just what I want is for the documentation to line up with what's actually needed for accurate coding, for compliance, and just primarily for representing the patient the way they really present. Primary care carries a lot of weight here, even when oncology is managing the treatment. So your note is very often the record that an auditor or a coder relies on, and what you document or do not document is what determines how that patient's condition gets captured for the year. So before we even get started, the biggest suggestion I would make to primary care providers is refer to your oncologist consultation. That's where you're going to find your highest levels of specificity. Okay, so with that, let's just go ahead and get going. In primary care, documentation drives more than the clinical record. It feeds risk adjustment through HCC coding and RAF scores, and that translates into reimbursement, but also into how complex your patient panel looks on paper. It also helps support the continuity of care, of course. Specialists, coders, and auditors are all reading your note to understand where the patient actually stands today. So here's the point I want to make, what I want you to walk away with. Primary care documentation is very often what gets reviewed. Even when oncology is managing the treatment, your note may be the one used to justify the code on the claim. So I do keep coming back to the 4 principles, same principles with providers: specificity, clarity of status, treatment documentation, and cutting out the vague language. Specificity means site, laterality, and type whenever you know them. So again, I say you can find these things in your oncology consult most likely. So saying cancer or even the type of cancer is usually not enough for anyone downstream. The status has to be clear. Active versus history is not something that a coder can guess at, or a CDI. So with that, we want to be careful about saying history of for a unresolved condition also. So treatment status matters too. If the patient is on therapy, even maintenance therapy, that is still typically considered still active disease. And the last thing I'd ask is drop those vague terms like stable. This doesn't translate into coding. It just creates a question mark in the chart. Again, touching on active versus history of. This is one of the most common problem areas that I see in chart reviews. Active cancer includes anyone receiving treatment or still under active management. That would cover chemotherapy, radiation, immunotherapy, and hormone therapy. A history of cancer means no evidence of the disease and no active treatment. So surveillance alone is usually history, but only if you clearly state that there's no evidence of the disease. If you do not explicitly state the status, we are limited in what we can assign, and that limitation shows up as loss risk adjustment or even worse, an overstated one. Okay, so this is an example of a scenario that comes up constantly, and I picked this one because it's so easy to walk past. A patient with a history of breast cancer is on tamoxifen and comes in for a hypertension follow-up. It's very tempting to skip the cancer entirely because it's not the reason for today's visit, but from a coding standpoint, it still matters. Because the patient is on tamoxifen, this is an active cancer. Documenting it as history would be incorrect and it would understate that patient's risk. So a simple acknowledgement that the ongoing therapy is genuinely enough. It doesn't have to be a paragraph, but CMS is requiring that we capture and document diagnoses that, besides the condition you're seeing the patient for in a problem-focused visit, other conditions that would affect the care, and of course a cancer would affect that, the care in just about anything. So we want to always identify the primary cancer when it's known, and if metastasis exists, they should also be documented clearly. So, for example, prostate cancer with a bone metastasis, both the primary and the secondary site need to be coded. If the metastases are not documented, the patient's condition is underrepresented, and that affects clinical understanding as much as it affects the risk score. So the biggest issues I see are not knowledge gaps, but habit gaps. Copy forward documentation, otherwise known as cloning, often carries an outdated cancer status forward for months. Unspecified cancer types limit how accurately we can code, and missing linkage between the related conditions creates confusion for anyone reading the chart later. And also failing to update status is what compounds all of this into errors over time. So these are workflow issues and they get fixed with small intentional adjustments, not a big training overhaul. And from a coding standpoint, neoplasms fall within the ICD-10-CM C00 through D49. The expectation is to use the most specific code available every time. Sequencing matters, especially when primary and secondary cancer coexist. And primary care often defaults to a history code out of habit. And that's what I'm referring to when we say history of for an active condition. That can undercode a cancer that's genuinely still active. So let's keep that default in check. So a couple things have changed since the last time I covered this topic. The first one is the fiscal year 2026 ICD-10-CM guidelines, which were effective October 1st, 2025, clarified how we sequence treatment encounters. When the main reason for the visit is to give chemotherapy, immunotherapy, or external beam radiation for a neoplasm, the encounter code from the Z51 series is the first listed diagnosis, and the neoplasm itself is reported as an additional code. So if your habit has been to lead with the cancer code on those visits, that is a shift that needs to happen. And then the second thing, and this is the bigger one for our risk adjustment work, the CMS-HCC version 28 is now fully implemented for payment year 2026, and the blended transition is over. That happened over the last few years. So we are 100% on the V28 model, and V28 uses 115 HCC categories and maps far fewer diagnoses codes to than V24 did as an HCC. So specificity in the documentation matters even more, not less. Specific to cancer, V28 removed the interaction term between immune disorders and the cancer HCCs. So if you were used to that combination adding an extra risk weight, that's gone. The connection is gone now. So we can't build any expectations around that. Okay, in this example, I want to show you, this is where documentation directly hits reimbursement. So active cancer typically carries a higher risk weight than a history of cancer, of course. If you document history when the cancer is actually active, the patient's risk score will obviously come in artificially low, and that's a real revenue. And your practice, your payer and your practice will not capture that revenue. If you document active cancer without support in the chart, you still have the risk of that being clawed back. It creates an audit risk instead. So, accuracy is what protects both the revenue and the compliance side at the same time. So it's not a trade-off between the two. We have to do both. Treatment status is one of the clearest signals of whether a cancer is active. Chemotherapy, radiation, and surgery are the obvious ones. Hormone therapy is the one that gets overlooked the most often because it still counts. It counts as active. And remission has to be clearly stated if it applies. So don't leave that implied. To avoid, we should avoid stable cancer, the terminology stable cancer altogether. It doesn't define a status that anyone downstream can code from. Okay, so here is how documentation evolves for the same patient. So this is poor. History of colon cancer. That's all it says. It would be better to say something like history of colon cancer, no evidence of disease, and now the status is at least confirmed. But that's not the best documentation either. The best would include the treatment timeline and the current status all together. So the difference is the clarity. Better documentation will get you better coding. And you're going to hear far fewer questions from an auditor or a payer. Providers should keep the problem list updated. Address cancer at least annually. Remember those, if those risk adjustable codes aren't captured annually, you'll miss that, capturing that risk. They reset every year. So even if it's not the main issue for the visit, clarify uncertain diagnoses instead of leaving them ambiguous. And document status at every visit where it's relevant. None of this requires long notes. It just requires intentional ones. And for coders, you should query unclear cases instead of guessing at them. Avoid making assumptions and code what is actually documented. Stay current on guideline updates, of course, and this year that means the fiscal year 2026 ICD-10-CM changes and the full V28 transition. And most importantly, partner with your providers. This is a team effort, and the best outcomes I've seen come from coders and providers that actually talk to each other, not just route queries back and forth. Let's talk a little bit about denials and audits. Most of the denials I see come from inconsistencies, not from complicated coding scenarios. Documentation does not match the code that was billed. Simple as that. Active cancer was documented without any treatment evidence to back it up. You have to validate every single code that you submit. Your treatment plan or some part of MEET needs to be there. MEET is the acronym: monitor, evaluate, assess, address, or treat. So you should be getting at least one of those elements. Unspecified codes get used more than they should. And this is so common. Auditors are looking for consistency across the whole record, and that's exactly what we can control. Okay, so the bottom line that I want you to take with you from this presentation is consistency. Specificity drives accuracy. Primary care plays a major role, even when it doesn't feel like it in the moment. Even if your patient is mainly seeing the oncologist, it's still up to you to make that documentation because you are managing the managed care. Clear status leads to correct coding, and teamwork between providers and coders is actually what improves the outcomes for the patient and for the practice. So it's not about perfection, it's about being clear and being consistent visit after visit. So with that, I want to thank you for your time today, and I'm happy to take any questions or comments in the comment field below, or you can reach out to me anytime through helpfordocs.com also. And if you find this content valuable, I do appreciate if you could like and subscribe. Thanks so much. That just helps me to share it with others and hopefully help other providers get this information. Thanks again.